Now, the TAVIA challenges, now it's become a common procedure. It will become more commoner like PCI. You will have about 10 different valves available in India, 2 balloon expandable, and at least 7 to 8 self-expandable valves. These are the challenges you'll have. You'll have access challenge, you'll have aortic anatomy, coronary anatomy, calcification, bicuspids, and valve-in-valve. In the 10 minutes, it will be difficult to touch upon all of these. So I'll probably touch on the most common difficulties we come across in Indian setup. As earlier on when Dr. Praveen Chandra showed, 40 to 50% of the cases we deal with is bicuspid and significant calcification. So that is a very challenging set. And access. We have got patients with very small femorals, very calcified femorals, very tortuous femorals. So we need to know how to deal with this. Small iliofemorals, calcified and tortuous. Obviously, ultrasound guided puncture is a must. And now IVL probably helps you to optimize these femorals to certain extents. But you do need to have at least one other alternative access in your center. If your surgeon is good, axillary or carotid is good. Otherwise, other optional is important. So femorals, tortuous, you can put stiff wire, you can use shock wave to optimize, surgical cut down, surgical graft, and one more alternative access for you. We have to remember class 1 indication for TAVR is against SAVR is transfemoral. So it's very, very important that as much possible you get a transfemoral access. And if it's not possible, then extrathoracic. Don't go for transapical or thoracic access. So this is one case earlier on, Gopi showed this. I don't think we need to do this anymore. This is a very bad femoral aortic aneurysm as well as severe aortic stenosis, other things. So we did a transcaval. That was the first transcaval in India, and it's the first proof of concept in the whole world as well. But I don't think we need to go that extent. Now we have got a much better techniques and as well as equipments to deal with this. Bicuspids is a real challenge. Every other case we go to proctor is bicuspid, or every case is a bicuspid. That's the problem in India. So this is a 70-year-old dyspneic angina, multiple comorbidities, as you can see. I'll just touch upon the important aspects of this case. The parameters, all the other parameters are good. The major issue is it is a bicuspid. It's a right non-fusion. Among the bicuspids, the right non-fusion is the most difficult one of the lot, because crossing the valve and especially taking a current self-expanding platform, it's difficult. When we get the next platform, when the FX comes, it will become much more easier. So it is a type 1 bicuspid. It's a right non-fusion, and it is horizontal. It's around 55 to 60. It will get more horizontal as you cross. So these are the problems. Bicuspid, small annulus, and the plan was to do evolute OR, but as part of the heart team discussion, it was already decided it's going to be difficult. You keep everything ready in terms of snare to bring it across and all the other sort of important aspects. So you can see, so the aortogram and the valve is crossed, the stiff wire is placed. And when you take the valve, it's very difficult. The valve doesn't cross. So you change the wire. You change it to a Landequist, try. The Landequist doesn't cross. Even with the Landequist, you are not able to cross the valve. The only other option left is you go with the snare, you cross through the snare, and you pull the valve up, cross it with the snare, and after that, it becomes a very simple, straightforward procedure, and you get a fantastic result. So these challenging cases will be there, and you should have the equipments available, and also the expertise available to do this. This is, again, another right non-fusion. I just want to show how the valve behaves, the current valve, with two spine. Until we get the next FX valve, this is a very difficult valve to take through more than 70 degrees. Yeah, that's how it looks. So you're trying to push, it will not cross. It goes down, and it comes up, and it will not, the nose will not cross. So this is definitely one for lifting with the snare. After lifting with the snare, you can see how horizontal this is. This is more than 90 degrees horizontal, almost going into 120 degrees. But once you cross the valve, then it becomes much easier, and you get a fantastic result. Once you cross it, it gets more coaxial, and you get a nice opposition, no gradient, and beautiful, and you can go and post-dilate, and you get a perfect result. So these are cases we do come across, especially because of the amount and nature of the bicuspids we have. This patient also had a femoral stenosis. On the way back, we have dilated, and we put a stent, so that is fine. So while they're doing it, obviously the access issues, majority of the access issues, you can predict it from the CT scan, and you can sort of optimize it with the IVL, and majority of these aortic issues, you can sort it out. Now these are the techniques you need to know in terms of the horizontal aorta. You can put a buddy balloon, buddy wire, snare assisted, various things, but you get comfortable with at least one or two techniques to support these cases. So in terms of the other challenges, I put this, should you do TAVI or not? These calciums, there is good calcium and bad calcium. Calcium in the leaflet is important to hold the valve, but when you have calciums like this, it's in the annulus as well as in the LVOT extending on the left-hand panel, you can see sort of significant calcium. That one, should we do TAVI? And if so, how will you do? And this again is the same, a big ball of calcium and quite extending more than sort of 2 centimeters into the LVOT. And this one, that's a ring of calcium as the STJ, because every parameter we look in the CT is important. The coronary heights, the sinuses, the STJ. So should this patient have TAVI done? And these kind of tortuosities. So when you get these beautiful 3D images, don't be sort of mesmerized by this. What is important is this axial cuts. When you see this, if you don't have calcium, these will straighten out. As soon as you put a straight sort of Landequist wire or stiff wire, it will straighten out. And this one with the effaced sinuses. Literally, there are no sinuses. Should we do TAVR? So for this, the answer is a good heart team is important. You sit down, you go through the image, you decide whether this patient is a SAVR favorable, TAVR favorable, SAVR unfavorable, TAVR unfavorable, all the parameters take into account and then do it. So the first one I showed, yes, we did TAVI. It was done with an Evolut with a fantastic result. The next one, this ball of calcium, that was done with an Evolut Pro Plus. That was the hemodynamics, no paravalvular leak, and zero gradient. This one, don't do it. Your self-expanding valve will not open. Your balloon expanding valve, the balloon will come up to the STJ. You will cause more harm. So this is a patient for surgery. If the patient has got truly non-surgical, at least some kind of hybrid where they replace that part and then you put a TAVR. But this is not a TAVI candidate. And this one, the tortuous femorals, as I said, the axial cuts showed there was no calcium. So yes, TAVI was done with the Evolut. And I'll just show the Landequist wire in position. You see, once the Landequist went in, it became a nice straight line. There is no tortuosity. So when you see this CT planning images, check the calcium, check the size of the femorals, and don't be fooled by that 3D sort of images showing significant loops. So this FA sinus, this was a complete surgical turndown, so we had to do it. We did it with double coronary protection and a triple kissing in the end. So you have a balloon in the valve, you have got balloon in both sinuses, and this is 2 years now since the procedure is done, and the patient is okay. So the hostile anatomies are common, especially we have 50% at least bicuspids. So CT planning is crucial. A good heart team discussion is very important. If the patient is really SAVR unfavorable, if you want to take these hostile anatomies, take this procedure with an experienced operator and a team, and have the bailout kits, including an ECMO, in place. TAVR unfavorable, hostile anatomies, but SAVR favorable, irrespective of the age, do discuss with your surgeons and get for surgery. So a patient-centered treatment for AS is crucial and mandatory in this sort of 2023-24. Thank you.
Thank you, Dr. Anantharaman. Can you just elaborate about the snaring technique you described?
You could, if you predict you're going to need it, like the second case, you could have a snare in the contralateral femoral and cross through that, and then cross the valve and take it all the way up, and then pull it up. If you are having in the middle of the procedure, you can go through the left radial as well. So whichever left radial or left femoral. The important thing is you have to cross through the snare. So your wire, catheter, and the valve crossing, everything is through the snare. In terms of where you hold the valve, the distal 1/3 of the crimped self-expanding valve, that's where, because that's where you need to pull to center it. Once you center it, while one person is pulling to center it, other person can move it. Once you cross the valve, then that's it. Then you just remove the snare and bring it up to the...
Thank you.
Thank you. Thank you, Dr. Anantharaman.